Welcome back to everybody to the We Fix Pain podcast. This is episode number 21 with our first two-time guest, Dr. Brett Winchester and Dr. Taylor Premer. Did I say it right, Doc?
Crushed it.
Thumbs up here. Yeah, he's a coffee drinker, so more likely than not, he's got some fabulous type of espresso going down, get himself pumped, ready, and motivated for this awesome podcast on neurodynamics. So this is the We Fix Pain podcast. We focus on neuromusculoskeletal issues that cause pain. It's injury to muscles, tendons, joints, nerves, and ligaments that lead to painful conditions. We focus on assessment, triage, diagnosis, and treatment of this condition. And today's special topic is the Neurodynamics World Congress that happened in November, of which Drs. Premer and Winchester were a big central role in helping organize that conference. But first, let me get you some information about our guests today. Dr. Winchester is the co-founder of Gestalt Education and the owner of Winchester Spine and Sport in Troy, Missouri. Dr. Winchester was the team chiropractor for the St. Louis Cardinals for several years and travels the world teaching manual therapy, rehab skills to physicians. Dr. Winchester is an international instructor for DNS, Dynamic Neuromusculoskeletal Stabilization, and is on the board of directors for the Motion Palpation Institute, that's MPI. In his spare time, Brett enjoys spending time with his wife, Sherry, and his two kids, Grace and Wade. He also enjoys water skiing or reading. And Doc, when we get you back to Austin, we are water skiing down here.
Heck yeah. Now you're talking.
All right. Dr. Premer is the co-founder of Gestalt Education and a chiropractic physician at Winchester Spine and Sport, also in Troy, Missouri. He was the president of Motion Palpation Institute at Cleveland University, Kansas City, where he fell in love with teaching and learning manual and rehabilitative skills. Dr. Premer is certified as a DNS exercise trainer and is versed in a multitude of manual therapy and rehabilitative techniques, including MDT, that's mechanical diagnosis and therapy, the McKenzie work, functional soft tissue and taping, dry needling, and neurodynamics. Dr. Premer has positioned himself as the go-to for getting high school athletes back on the playing field in his community, especially in the treatment of the acute ankle sprain injury. He and his wife enjoy exploring new coffee shops, hashtag get you here in Austin, try some coffee, and traveling to new destinations in their free time.
Right.
So guys, how did this Neurodynamics World Congress, how did this come about?
Well, it was kind of a funny story, Dino. We've been lucky enough to spend so much time with Michael Shacklock in the last 3 years, honestly, bringing him over to teach for us. And so last year, we spent basically 2 full weeks with him. We had a week where we did DNS baseball with Brett teaching, and the neurodynamics upper and lower quarter in Phoenix at the Chicago Cubs facility. And then that next weekend, we actually traveled across the country to Florida and did the exact same thing in Jupiter. And so you can imagine that 2 weeks straight of hanging out with an absolute gem like Michael Shacklock, certain things get discussed and amazing conversations we had and things like that. And then it honestly got brought up of how much integration there was with first DNS and NDS, or neurodynamics and DNS, and then also how much crossover there was between things like Antonio Stecco's work with fascia manipulation. And then we talked about Michael Leahy and ART's long nerve courses. And then also Stu McGill talking about more central mediated things. And I think that the crossover just started to come naturally. And that's literally how we started to build it. And we just said, wouldn't it be awesome if there was a weekend that was the lens that we're looking through everything was neurodynamics, but the treatment side of it was a little bit different. Because that's really, we feel like, is the absolute like amazingness of neurodynamics comes with the assessment piece. And then the treatment wise, not that there's nothing wrong with the treatment of neurodynamics, the treatment's amazing when it's indicated, but the other treatments in our toolbox have such big influence on those assessments.
What really ended up happening too, and this wasn't the original goal, was that it really kind of became on the side, almost like a soft tissue who's who. And it was really, what was really special about it was we had Michael Leahy, and he did a couple workshops and demonstrations. And then obviously you have Antonio Stecco. So we had those two together, and they've never been together before. And I thought like their conversations together, I thought were really, really good. Dr. Leahy, you know, his new thing that he's talking a lot about is actually the fascia. So, you know, we had spent so much time, myself especially, in active release techniques. So to hear him kind of switch gears on what the mechanism is for how ART is working, and then to start like opening up his model to what could be happening with the fascia when we're doing ART. What's next down the road for ART in this world of fascia? He touched on all of that, and I thought him and Antonio played really well off each other. And then we had Jeffrey Bove there. So Jeffrey Bove is, ironically, he's a chiropractor. He has been hidden up in the Northeast. No one knows who this is, but this guy knows more about the neurophysiologic function of nerves than anyone else in the world, and he's one of us. So he was like he would get a 10-star for what he did that weekend. He was so good. We had David Seaman there to talk about. Dave's really kind of dove back into some neurologic ideas with what's happening when we treat our patients. So that was really refreshing to see him. Him and Jeffrey are kind of like old best friends, so they had great dialogue. We have the expert in the world in centrally mediated pain there with Annie O'Connor. And she, of course, was Annie, which is just literally the best physical therapist in the world. And she was just so good having there. And then I did the DNS part and I did the manipulation part. And it was just, I think we covered everything. And it was one of those that we were nervous about because we kind of felt like we don't want this to be a commercial for a bunch of techniques where you're just getting teased with a bunch of stuff without content. So what we did is we sat down with Michael and we had a year to kind of plan it, but we purposely set people up to where like that wouldn't happen. We were still nervous though. So it ended up, I think the people that were there, most people say it's just literally one of the best. It might be one of the best, like all-encompassing multimodal seminars that have ever gone off. Like it was that good just because people were in the mood to integrate. And it was special.
And that's kind of like the definition of Gestalt is integration. And so that's what this weekend I think really highlighted is, yes, we were focused on NDS and neurodynamics, but it was true clinical integration of people. Even the crowd was getting entertained, like talking about different patients and case studies and how it could apply. And I just felt like it was good integration of everything together.
And I think too, people really humbled themselves. I mean, we even had the president of Parker's kind of the leader of the profession right now, Bill Morgan. He did a talk on stenosis that was just great. And I felt like everybody usually, they're used to being like the main peacock in the room. Well, everyone was just very, very humbled. And everybody was wanting to hear each other talk or do their workshop just because they were wanting to learn from each other. And I thought that was also the special thing about it. Because you're so used to dealing with like knockoff versions or B-list versions of the material. So I felt like from the beginning, we were like, let's just get everyone here in the same room. And no one told us no was the other good thing. So we literally got every single person that we wanted for it. And I think it came off a lot better than I even would have thought.
So my analogy to the folks listening out there who don't know the names that you guys are referring to or don't know the history or the story of that is like, you guys are general manager for like the New York Yankees and you put together a super team. And then instead of, pardon my language, shit in the bed like some super teams did, everybody came to perform because they all performed as a team. One person building off the next material and learning what the other person was doing to make what they were going to clinically do or research way more effective. So you pulled off a really functional super team, basically.
Yeah. Well, I think like the people that are plugging multiple different systems in, which is going to be all your listeners, knowing what technique system is necessary to turn a certain case, I think is a really important point, which means if you don't have neurodynamics in your toolbox, what is the case that you don't have a tool for today? Because there is crossover in other techniques. Like, some people are going to respond to manipulation. Some people are going to respond to soft tissue, whatever it might be. But what are the cases that need a real sniper targeted approach to get better and exposing what those are? And I felt like that got exposed over those 3 days. And I think that's what we all want to know is like, if we're going to give up 3 weekends of our life to become certified in one of these systems, which patient profile does that actually help me treat today? And if I don't know that, then who do I need to like find or refer to make sure that gets done to get that patient better?
Let's break this down speaker by speaker. So we kind of have a 30,000 foot view of the why, the necessity behind this, and the names in there. So I want to go kind of speaker by speaker here. So Before we do that, one quick question. Neurodynamics. What is neurodynamics? Let's start with that definition. What does that mean to you guys?
So neurodynamics is basically the study of how nerves are sliding in and out and through the container of our body. That could be the skin, that could be the fascia, that could be the muscle, that could be innervated tissue. But like if you go through Michael's work, what you'll see is like that's what you think that it is, but then it is a lot about neurophysiologic function of the nerves also. And the real valuable lesson that we learned when we really dove into all the coursework was when I would have been using like neurodynamic as a treatment, Michael Shacklock probably would have had that patient in a static opener resting the nerve. So it's like this weird twist of irony in that like what you think you're going to be using with neurodynamics, actually, it's more about like understanding the problem and being very respectful of nerves. And like sometimes nerves just they need opening, they need healing time, they need rest. And sometimes nerves need sliding, sometimes nerves need tensioning. And it sounds so easy, but then when you hear Michael kind of lay it all out, it's definitely on a continuum, no different than like a low back case would be where, what we're doing today or tomorrow or next week or even 3 weeks from now, that can all be kind of modulated and we can dose that appropriately. And thank God we have Michael Shacklock who's mapped that all out for us perfectly.
Yeah, I agree. How the nerves are interacting with everything around it. One of the things that I never really appreciated is how much he talks about central nervous system too. Like how much the spinal cord is influencing with even peripheral extremity issues and things like that. And so it's literally a giant, like a 30,000-foot view of how the nervous system is reacting in the periphery and central.
Guys, how has Michael Shacklock evolved this? I know from my readings as an athletic trainer in the early 2000s, I remember briefly touching in my master's curriculum the works of like David Butler, and it seemed really rudimentary, and it was way over my head in 2002, 2003. And I've noticed an evolution in kind of how he describes it. If you watch YouTube videos, or he's been a podcast guest twice for you guys twice, if I'm not mistaken. How has he evolved this over the past 20 or more years?
Well, it's interesting. If you would have asked him the same question, in his mind, he ironically feels that he hasn't. He said one of the more epically savage things I've ever heard a man say is he said, well, the research is going to help reinforce what we're doing, but if the principles are good, it shouldn't matter if the book's 20 years old or if we're looking at it 20 years from now. The principles are going to, they're going to hold true to what he had originally taught or what he wrote about. But as time goes on, through the likes of the Jeffrey Bows of the world, like it's all kind of supporting the original hypothesis, which thankfully a lot of his original ideas and hypotheses have, come out to be truths, if you will. So, I think that what you're going to see is you're going to see neurodynamics as far as the techniques and things like that. That part's going to stay kind of similar. You're going to see more and more research that's going to support what the original principles were when him and David in the 1990s, they were working, a lot together. David kind of went more down the centrally mediated pain route. Michael Shacklock was, stuck more in the peripheral, but they both know each other's world really well. And then I think the future would be no different than like if, people believe in like performance care, maintenance care, whatever you really think about that. But like you potentially could, not have a neurodynamic problem, but be seen one of us just to be sure that the neurodynamic system is sliding the way that we want and things like that. And I think like that may be like a future idea, like a movement prep for the nervous system and things like that. And we're not to pull the sheet off all of it, but like we're, that's kind of some things that, we're currently talking to Michael about on what that might look like. And he's been thinking about it too also. So
I think the evolution too. I took my first full neurodynamics course 5 years ago now, and I think just like any other system, if we talk about DNS, we always say DNS is, DNS 5 years ago to DNS right now is completely different. I think it's because the education's getting a little bit better. I just think Michael is getting a little bit more clear in how to convey the message. It's sometimes it's easy, it's difficult to get that information out of a textbook until you see it in person and you can actually see Michael do it on a patient. You can see it happen. And to reflect, like you said, I mean, we had some very big epiphany moments of him actually sitting through the DNS courses and actually kind of thinking about how we can utilize developmental kinesiology for neurodynamics and how those two can actually play together. And so I think you'll see Michael branching out more, especially after this weekend that we had with all these other people, of how these other systems specifically fit into neurodynamics. We're kind of putting words into Michael's mouth there, but I think he'd be okay with us saying that I think he's thinking more integration, which I think everybody that's doing good things in this career, in this field, is thinking more integration.
I think too, Dino, if you can, if the listeners can imagine like neurodynamics being its own audit or baseline for your cases. So, if most of us are playing with the same playbook, we're talking joint blockage or trigger points, other neurologic information, functional testing, all these things that we're coming back to audit the patient. Well, neurodynamics should be a part of that. So what you're going to find sometimes is like we can do an amazing DNS session with a patient and completely change a neurodynamic baseline. I mean, like drastically change it. So I think like, as we move along with our relationship with Michael's impressed also with seeing like how that can change that, And then I feel like if you can imagine a puzzle, there's a time and a place when we actually need to break up the, call it whatever you want, the densification, the adhesion around the nerve root. And, we can use our techniques like active release. And I always feel like, the younger generations, they may not appreciate a guy like Michael Leahy as much as they should. Like, the mechanisms can, that the reason it works, we learn more and more about that every day of our life, but like, you cannot deny that active release technique is one of the most powerful techniques that are out there for soft tissues. And there's a reason why just about every single professional team in the world is going to have access to somebody who understands active release and other soft tissue techniques too. But I mean, if you're looking at the Mount Rushmore of soft tissue techniques, Michael Leahy's on there. I mean, there's no doubt about that. So, swerving into what he's done and really kind of appreciating where even in the neurodynamic hospital, what role active release might have in those cases, or DNS. We believe that DNS is like the overreaching lens that we're looking at every case on. So if you're having nerves that aren't sliding well through tissues, one of the reasons is maybe because the brain isn't utilizing the muscles correctly in whatever area we're talking about. So besides like getting the nerves to move inside better. What's that?
Oh, there's a perceived threat to the nervous system because of somehow, some way, a loss of stabilization somewhere in the locomotor system, to which the cleanup, the audit is put them in a developmental position and, see what happens. If there's less perceived threat, cleaner pattern, greater strength, greater range of motion, whatever that audit may be. Less threat though.
Yeah. Better tone distribution, like, I mean, what's a hard concept for, especially as a student, is like, if you're not using the muscles exactly the way that you want around your shoulder girdle, it will change, for example, the way you're utilizing your pronator teres for gripping. So like if we have a median nerve entrapment in our pronator teres, we need to get it sliding better. We can do all the techniques that everybody will know, but maybe the far reaching treatment could be better utilization about how the brain is picking the muscles in the upper extremity, So, I mean, it's vast, like there's layers to these cases that people may not be realizing.
Let me transition. You brought up Michael Leahy and active release. So active release is often bastardized. It's seldomly appreciated for the skill that you need to be good at it, like Mike is. What is and what isn't active release, just for the novice that's listening to us, for the entry-level person? What is it and what isn't it?
It's not compression. That would be the number one thing that I would say. And so it's more about tension versus compression. So when we look at people who aren't good at it, I mean, I think that's like maybe the biggest mistake that gets made. The other thing would be all the miracles in active release occur also at in range. So I feel like sometimes when I watch people do ART, they don't do a good job of like taking the joint through the full range of motion, whether that's active or passive, and therefore they miss out on that. A good example of that would be the subscapularis, which Michael Leahy, he told me way back when, he said, if I could do 3 moves, it would be the pronator teres, the subscapularis, and iliopsoas. And if you just did those 3 moves, you could set up a huge practice. So I think like respecting that, but on the subscapularis, like sometimes people have so much tension and tone in like the front part of their latissimus that you can't get the arm or the upper extremity to the end range to get the subscapularis treated effectively. So you need to be like kind of layering through and get rid of that tension in the lat. Therefore, you're even able to get to the end ranges of abduction and external rotation to release the subscapularis. So I think those are like little hidden things that aren't talked about, but that I think would be good tips maybe.
And I think too, like, I think ART, it's not pin and stretch. I think that's a misnomer. Like you're not just pinning something down and then taking it through a range of motion. It's, as Michael kind of showed that weekend, he did a couple demos that were very awe-inspiring. I mean, like very concentrated palpation, specific palpation, and then targeted treatment. And so I think that's maybe one of the big things that gets missed in ART is the assessment piece. Like being able to palpate and be able to understand functional anatomy to the point that you can work through a patient doing a functional movement, identify the thing that needs to be treated, and then applying the treatment, understanding the biomechanics and the functional anatomy of that area.
And I mean, in a world where evidence-based medicine is trying to tell us that there's no reliability in palpation, you should hear Michael Leahy talk about this topic. Like, it is so inspiring because like when you're young and you think someone's telling you that there's no reliability in palpation, to hear Michael talk about what's possible through palpation was even inspiring for me as long as I've been around, and it reminded me a lot of like a Dr. Levitt and some of these others that have really relied not too much on their hands, but a lot on their hands from a diagnostic standpoint. And I feel like what you're going to see in Western medicine is this pendulum has swung so far to where like people are now like actually clamoring for doctors who are laying hands on their patients, and even for myself, who I've been around not as long as Michael Leahy or Levitt, but like as I get older, I realize how much I'm relying even on my palpation. It doesn't mean you're not observing your patient and doing functional tests, but like palpation is going to tell you a lot. And I feel like the younger students, they're being told that there's no reliability in palpation. So they're just like forgetting about that skill. And I think that is a catastrophic mistake for what it's worth.
And I think that was reflected during the weekend. We'll get to Antonio Stecco. Michael Shacklock talks about palpation. Huge part of the assessment. Antonio Stecco, same thing. Michael Leahy, same thing. Annie O'Connor talks about palpation. We talked about palpation with manipulation, so it's there's common ground across there.
So, what is the mechanism by which ART helps? This has often been debated, and I think early on it was to focus on the adhesion model. Sounds like Mike has gotten away from that strict adhesion model and kind of gotten more into other mechanisms by which ART could be effective. Where's the stance on that as the adhesion applies to neurodynamic sliding? Where does he stand on that?
Sliding of tissues, 100%. So but what's a little bit ironic is now the Italians with the Stecco group, they're actually proving that like we can see densification on imaging. So it's not to say that we're back in the adhesion fibrosis model for ART, because there could be a lot of different mechanisms at play. But the latest theory, when we've been with Michael recently, is you hear him talking a lot about the benefit being that we are reestablishing the sliding of the different layers of skin, muscle, fascia, and then like even like diagnostic ultrasound, for example, being a way to and your buddy Capo and Austin, he's talking about it. And of course the Stecco. So I mean, that may be the piece of technology that we could really use to objectify everything that we're talking about.
And I think too, Stecco talks about being the increased viscosity of the hyaluronic acid. That's their idea. And I think Michael Leahy may be a little bit different on that, but I think he's probably closer than what we realize to being that. And it being, like you said, Brett, the inability of the tissues to slide and us reestablishing sliding through manual therapy and end range movements. I think that you can make a huge argument that that's probably not talked about enough in the end range movement.
And on our podcast with Antonio, we point blank asked him, we said, do you like try to decipher the difference between like a muscular trigger point and a fascial densification? And he didn't even think about it. He's like, no. He's like, to him, densification is densification. And that's where I think like maybe the future, I kind of believe that like we can distinguish a little bit, because if you buy into Travell and Simmons trigger point charts and model, you will see that, you know, you have those trigger points, but then we also have densification in other areas. And like I've noticed that, like, for example, a massive densification we talk about like above the patella, just for as an example, or like areas in the lat. And it's like there's areas that you find in the body that aren't described in Travell and Simmons work. I mean, you couldn't miss it if you tried. You can clearly feel that this is, you know, a change in muscle tissue. So, you know, whether or not it's important that you distinguish between the two, I guess we don't know at this point, but maybe that could be part of the future.
Let me circle back. You brought up Stecco, and that's kind of where I was going next. What is this concept of fascial assessment, fascial manipulation? It's kind of one of the I want to say the newer tools in the toolbox of soft tissue, but the emphasis and the research behind it is kind of newer. So what is fascial manipulation?
Well, I think like, I mean, we can go way back to the early 1900s where, you know, when we look at how muscles are connected, I mean, if we were, for example, going to separate your anterior posterior oblique sling, you would literally need scissors, a knife, or a scalpel to be able to do that. So if we all can agree on that, you know, how are we all connected? And that glue that we're talking about ends up being the fascia. So we have, you know, we have superficial layers of fascia, we have deep layers of fascia, and they're not only connecting our muscles and our soft tissues, but also like our internal organs. So the fascial manipulation camp is all about talking about what we need to do for these patients to get this densification in the fascial system. And they're big proponents to think that, you know, if we don't have an elbow or we don't have a knuckle, then these tissues don't just free up on their own. So we have a real specific, we have points of fascia, which,
right here.
Yeah, for example, that, you know, that they really don't look all that different than like acupuncture points and, you know, other people that have described, you know, areas of restriction in the body. So, you know, they have a map for us, but then we also can use palpation to determine these points. And that's nice too, because like if, you know, someone might take the course that isn't gifted in palpation. So these charts become really, really helpful because it kind of gives them a roadmap to know where to be treating. So, yeah.
I think one of the best analogies that Antonio told us while we were learning from is it's kind of like if you imagine you have a snag in your shirt. So if you're watching on video, if you have a snag in your shirt here, then your ability to move down here is altered. And so what's cool about the fascial manipulation is that there's a global idea here, a global look, meaning just because you have symptoms down here or you have a dysfunctional shoulder, your cause could be the opposite shoulder because we're so interconnected. And I think that that's a really cool concept, especially we're obsessed with regional interdependence. We're obsessed with not treating the sites of pain necessarily and things like that. And so fascial manipulation gives you a little bit of a roadmap because of those intricacies of how they're connected together. And then the treatment's based on manual therapy, increasing the viscosity through heat and through friction.
Yeah, you're referring to basically the work of Thomas Myers, looking at slings, looking at kinetic chains of motion, and he did it through an anatomical perspective. But to your point,
you know what's crazy though? Like those slings, I mean, McKinney and Logan in the 70s were talking about it. I mean, Lovett was talking about it in the early 1900s. And to be 100% truthful, like in the 1990s, like Andre Vleming, Snyder's, Mins, Oscar, that group out of Amsterdam, they were really talking about it too. So yes, to Tom Myers. Tom Myers has really been the one to kind of like expose it all. But I think I always try to do a really good job of like giving proper credit along the way, because there's been a lot of people that it's not only Thomas Myers, what I'm trying to say.
No, he made it more popular today with the book and then the illustrations too, and more user friendly. But to your point, I am familiar with Fleming's work. That was probably the genesis for, you know, and then he had somebody that inspired him, kind of like neurodynamics. You can trace that back to Alf Bragg. Literally looking into cadavers.
Yeah.
Oh yeah. And then what's its spanned is kind of what we utilize, but we forget somebody had to start that up. So what's the mechanism by which this fascial manipulation work? I know like at one point in time when I learned the concepts, we talked about twisted fascia, we talk about fascial adhesions, deforming fascia. And I'm more in the neurophysiological camp with the mechanism. I'm sure that you can, with enough time under tension, time under force, start reducing some adhesions, but theoretically 1-2 treatment sessions, you're not doing it. How does that work? How does this fascial manipulation process work?
Well, it's debated big time, and I think how Antonio taught us, or how we learned it, is it's literally you're changing the viscosity of the hyaluronic acid in the tissue itself. And so how they explain you do that is through heat and friction. And so by increasing the viscosity, you allow those tissues to slide better. Now, I know Antonio would say that there's definitely a neurologic component to that, meaning when we put our knuckle or our elbow on a tissue, we're touching the skin. There's so many layers we're going through, and so I think that can maybe be debated on the actual mechanism, but that's what they believe, is that they're increasing the viscosity of the hyaluronic acid, and then therefore they're increasing the sliding. So then you can get lasting effects because now you're reintegrating those tissues back into function.
I think too, they were able to expose that there's actually an active contractile component to fascia. Whereas I would have really kind of believed that to have tightness in fascia, you really would have needed tightness in the muscles around that area to create that. And they've kind of proven that not to be right, actually. So there is that. I mean, that's one of the mechanisms to have tight fascia. But fascia can be tight within itself without there being tightness in the muscles around that, because there is an active activation component of fascia. And that's like what was really eye-opening for me. And that's why they have a technique system. If it was as simple as just, the muscles being the etiology of the problem, we would just do DNS and everything would be fine, But I'm a believer in it for what it's worth. And I think that like the techniques really speak for themselves. I mean, we've seen Antonio work through at this point tons of patients. And I mean, he's pulling rabbits out of a hat like Michael Leahy is, and other people and other things. So, I mean, yeah, I think it definitely is going to end up having its place. It's just a matter of like anything else. Like, there's always that, return to the mean where you think, oh God, I'm going to be doing this on everybody. Give it 3 months and you kind of see like where it's really good for and how it blends in the bigger picture.
Yeah, I think we've been on this journey. We've been on this journey for 2 years now.
Mm-hmm.
And we're using it every day. I mean, it is a vital part of what we're doing in practice. And because the effects are long lasting, which really surprised me. When I first took it, I was like, yeah, we'll see how it comes back visit to visit. That's always the question mark. And I will tell you, like visit to visit, these fascial adhesions are changing, which is pretty amazing.
Their research is showing their research hasn't shown like from a histological standpoint, but from a pain standpoint, that when they follow up with these patients, like even like a year later, that they're still doing really well. So I guess the next research would be like from a tissue sliding standpoint 1 year later, what that might look like. But that's where all the research is probably going to be headed. But
let's move on. Let's transition. One of my favorite people to watch lecture, Annie O'Connor. She's got a unique style, unique personality. She had a lot of songs and Chicagoan, just like myself, right?
Yeah.
So a lot of hometown advantages there. So for the folks that don't know, what is Annie O'Connor's work? Who is she? What's her work? What does she do?
Yeah, I was texting with Annie this morning. She's just one of my good friends, and I just feel like she's understated, which is hard to believe. But I feel like, I mean, you can go somewhere in the country and a room full of physical therapists don't know who Annie O'Connor is. What Annie is so good at, what she's got so many gold medal qualities, is that what people don't know is she's probably top 5 in the world at neurodynamic treatment. She's amazing with MDT treatment. She's gone through the whole GIFT program with Gary Gray. So like she has, and no one knows this about her because she's so good in the centrally mediated camp. So she and her co-author, Melissa Kolsky, they basically, created the book World of Hurt, and they basically expanded SMART's original classification system of central mediated pain, or at least highlighted it. And they're basically taking the central mediated component and they're doing that with what you and I are doing with like problems in the periphery, like when we're, talking about derangement, or we're talking about dysfunction, or we're talking about different, classifications. They did that. And they look heavily in central sensitization, motor autonomic, and affective pain is like their three big things that they're looking at. And I think what they exposed, and they looked at 20,000 patients at RIC, and what they found out was over 35% of these so-called orthopedic patients actually were in the centrally mediated camp. So 1/3 of the patients that you and I are seeing would potentially maybe need a centrally driven treatment. Now, one thing that, I'll just speak for myself on this, is that a lot of us are good clinicians to where like you're already addressing that. You're just already kind of baked into the cake without even realize you're doing a good job with it. Like if you're doing functional medicine, or maybe you're just a good inspirer, you're kind of a life coach, whatever those soft skills are. So like a lot of people, they may not be officially throwing them in that classification I just went through, but you're already knowing how to handle that chronic pain or that centrally mediated case better. So Annie O'Connor also she's a researcher, but not really a researcher. She has 30 years of experience of getting her teeth kicked in the clinic. And that makes her different than all the other people that are in that camp. And because of that, like she brings a really unique perspective. And I think like with her training in MDT and neurodynamics and with Gary Gray, I think like she's got a lot to offer. So she's I just can't say enough about Annie O'Connor and how good she is. And then if you're around Annie O'Connor, like you cannot not love the lady. She's just the best.
The room lights up around her. The room lights up around her.
Exactly.
Yeah.
Exactly.
She makes that room better.
Yeah. So true. So true. And I think her contributions to the weekend was we tasked her with pulling the weekend together because she knows all those sides better than anybody. And I thought that's what she crushed on the weekend, is we gave her that kind of the last lecture on Saturday of, hey, we went through all of this stuff Friday and Saturday. And now what the hell does it mean when there's a patient in front of you? And so I think her beating the drum of classifying your assessments and putting those patients in the right hospitals is the most important thing we can do. Being amazing at ART is amazing. Being amazing at fascia manipulation is amazing. Understanding neurodynamics is amazing. But then understanding the broad overview of where those patients actually fit was Annie's big contribution. I think that's the drum that she's been beating since you've known her.
Mm-hmm.
I haven't known her as long as Brett, but she's kind of the integrator, if you will, of this world. So that was her big contribution to the weekend.
Yeah, I agree.
Yeah, but what Annie helped me figure out was kind of a roadmap, and the roadmap is the cases that I was failing at was, were they even in the right spot to begin with, and what tool I can bring out of my tool belt to treat that problem. So kind of hearing her talk and reading her book and all that really kind of helped me take a step back, detach, and realize, crap, I'm not classifying these patients right, and it's impacting my outcomes, and more importantly for the patient. So hearing her gives you a step back, a 30,000 foot view. What am I dealing with, and can I actually help this patient?
And different than like a lot of gurus too, is I feel like she's very understated. Like she knows way more than she's given herself credit for. And when you see that come out, I think it's so beautiful because it's just really good, soft human qualities all around with Annie.
Yeah. All right, let's move on. David Seaman here. Some folks that are chiropractors may have heard him from the nutritional component. How does David Seaman's work, especially in anti-inflammatory diet or some of the things that he's exposed, tie into the neurodynamics conference that you guys put on?
Oh, I think 100%. And before, like, really the only person in the world that was speaking of a paleo diet way back when I was a student was a guy named Loren Cordain. Or maybe like Rob Wolf was just kind of getting busy. And so what I always give Dave Seaman credit for was he was talking the deflame or anti-inflammatory diet. He's been talking about that for like literally 30 years now, and even before it was cool to be talking about it. And I think what he did is like, he just made it real simple for people. Like at the end of the day, if you could convince your patients into eating meat, fruit, vegetables, nuts, eggs, a little bit of dark chocolate, and if you like a glass of wine at night, you're going to have miracle after miracle after miracle.
What about Trulies? What about Trulies? Do those fit in?
Well,
that's up in the air.
Yeah. Our problem is we just drink too many of the Trulies, so we probably cancel out.
I'm asking for some friends.
Yeah, right.
Never trust a man who only have one seltzer, as we say. But
That's it.
but anyway, so I mean, like, I think if you can get the inflammation out of the diet, which honestly, the one thing I'm learning is it takes good clinicians to be able to get their patients to actually do what you're asking them to do over a period of time. So maybe what's missing in that whole model is like, you better come hard with them to get them motivated on why they need to make that change. Because it's proven to be hard for modern Americans to change their diet. But I think what we're seeing in the disease process, we presented a paper in our last staff meeting where if you can get somebody who's, in their 20s or 30s, and if they're able to just adopt a Mediterranean diet, which even keep in some decent grains, they're adding on average 9 years to their life. So like, wow, that is nothing. I mean, that's a long time. So
it's a long time. In the longevity medicine field, that's a long time.
We're learning that, the diet is really, really important. And I mean, that's like one level. And then we can even layer on the functional medicine component, which I know your wife is a complete superstar in that department. But that is like, so you have the David Seaman deflamed diet, which is going to help a lot of your patients. That doesn't help everyone. Then you have the functional medicine layer. And then that final tip of the spear might be like Western medicine, when we have to ask, have our medical doctors kind of help us, with these real difficult, complex cases. But a lot of our patients, they're entering the funnel in the wrong direction. So we would love for them to start with a good old fashioned dietary change and then like work them up the pyramid instead of the other way around. And I think even though we were talking about nerve function that weekend, I mean, this has a huge effect on nerves being central. I mean, the diabetic patient's a classic example of that, So if you're dealing with polyneuropathy or whatever the diagnosis is, when you have inflammation of the nerve beds or the nerve tissue in general, a dietary change in itself and some real simple supplements can be life-changing.
And I think, like, bringing it back to that weekend, what Dave is also known for that nobody really knows about. I mean, the dude was writing about disc degeneration and neurodegeneration. I mean, before he really was beating the drum on the diet. And so what he brought to that weekend was classifying or actually showing the mechanism of how discs can become inflamed and become painful, and the cascade of inflammation that occurs after that. So, it's easy for us to run to a medral dose pack and things like that for our patients with big acute disc injuries. And he made a pretty good case for one, supplementation, and then two, dietary change or removing the inflammatory cascade from the diet to help those patients with recurrent disc injuries. Recurrent derangements would be another classification, or those patients with spinal stenosis that are long-term chronic pain. So
yeah, just to recap on the work of Seaman, it's basically reducing risk factors that sensitize nerves or the pertinent soft tissues. And sometimes it's like the hamster wheel. We keep spinning around on these mechanical treatments. Sometimes the breakthrough is something that day in and day out, little things matter, diet, nutrition. And then having the soft skills, like a really good, and this is why I appreciate Annie O'Connor. She's really good at forming great relationships with her patients, where she can dive into the weeds. They got to trust you. They got to like you. And that's kind of the combination of Seaman and Annie at play there, having the knowledge to know that matters, and then having the soft skill to kind of broach that. Let's move on to Jeffrey Bove. What is his work? How has he contributed to the field of nerves, peripheral nerve injuries, and neurodynamics?
Well, what's interesting is like if you were to ask Michael Shacklock or David Seaman, like who is the expert in the world in what you just said, they would tell you Jeffrey Bove. So this guy is maybe the most misunderstood person in the profession, but he's really kind of known for like the neurophysiologic component of inflammation of the actual nerve, and nerve function. And, that's where like a lot of his research has been. And he's done a lot of it, most of it actually in lab rats. So he actually has a government funded lab rat, wet lab actually in his house. I mean, he is amazing.
My wife would go for that.
Yeah, I know. Yeah.
But like he understands from a neurophysiologic standpoint exactly what's happening when a nerve actually gets inflamed. So he's not big on his expertise. It's not like the sliding of nerves and things like that that obviously Michael's so good at. He's more into the actual neurophysiologic function of the nerve. So, and that's what all his research is basically looked at, and in healing nerve time, stuff like that. And I think that, you know, it can be boring for a lot of people, but if you look at what he's done, it's actually, you'll learn a lot as far as like why certain cases need resting and other cases do not. And even like on a pharmaceutical component of treatment of nerves and how those have a role, and all those things can be applied to his work.
And I think now he's starting to dive into manual therapy, which was kind of interesting hearing him talk about. He's actually doing manual therapy on rats with nerve injuries, or when he's creating these fascial adhesions or other things like that. And so he's actually starting to dive into what's actually happening that may explain some of what's going on with manual therapy, how fascial manipulation is helping, how ART is helping, and things like that, which I think is cool.
And I think everybody expects Jeffrey Boeb to be a hater. He's actually not. He just wants you to show him how it's working. And I think like if you can show him that, he doesn't even ask you to bring a bunch of research. He just like for his own curious mind, he wants to know, that way he can wrap his brain around it. And I felt like he was amazing that weekend. I mean, like he was, people loved him and he did a great job. Actually a really captivating lecture too. Like really did a good job on information that's not very exciting. He did a really good job.
Let's finish up with your piece, Brett. And your piece that I want to kind of bring it back to is the DNS. And I think people kind of viscerally understand it, but how does stabilization, development of the locomotor system play into peripheral nerves, peripheral sensitization, and neurodynamics?
Yeah, I mean, I think that, you know, the three of us are all skeptics on all things. And that's what, you know, gets us to a point like this. But the power of DNS is so powerful to me. Like, and it's hard because I don't want to just say, oh, DNS is amazing. I just feel like it is in a difficult situation. Give us 10 patients and you will see the magic of DNS being exposed. So what I like to teach is like, if you can imagine the normal developing baby and what the joints spring like, what the soft tissues feel like, what the neurodynamic tests would be like if you did it on them, that is what we would call neurologic perfection. And that is kind of what we're shooting for in all of our patients. So, you know, if you have an 80-year-old stenotic patient that you're seeing as a new patient, in your mind, you're trying to return them back to this first year of development when everything was so neurologically perfect. And DNS believes that we can put our patients in these developmental positions that we're all in the first year of our life. And when we do that, the central nervous system will learn how to reorganize how all the muscles are being utilized. So it's not about just like turning on the serratus anterior, the glute medius of the hip. It's about teaching the brain to redistribute and use that in the most effective way. And we use the developmental positions with the other principles of DNS, those being joint centration, which means if we put a normal developing baby in a developmental position, then they're always going to put their joints in this centrated position that we're speaking of. Therefore, we're given the best opportunity for their brain or their central nervous system to utilize the muscles. And like Dr. Kolach says, the trigger point or the densification or whatever we want to say is actually not in the soft tissues. It's in the brain. And it's in how the brain is actually using this program or this hardwiring engram, if you will, to strategize how to move these levers, our bones. But not just that. I mean, we need our smooth muscles to move food through our tubes, through digestion, to open and close our apertures for speaking. And so the muscle system is, obviously imperative for human function. And it's not just in our musculoskeletal system, it's throughout our body. And we at DNS believe that DNS is one way to access literally how every single muscle is being utilized in our bodies.
Gentlemen, I appreciate your time. Let's close this down here. So Brett, give me your top 2 closing thoughts. Taylor, you'll be second. Top 2 closing thoughts. What do you want people to remember or learn, whether it's from this podcast or from the conference at large?
I think like one thing we've really tried hard in the last couple of years is to really truly go all in on integration, which is to be very, very careful not to fall into the trap of like just looking at one guru, to be willing to do a deep dive into a system, but then be able to take a step out and also see what the weaknesses of that system are. So we're so used to talking about the strengths, but let's also address like what could be some of the weaknesses, And I feel like weekends like that really, yeah, and we try really hard never to bastardize anybody's stuff. So like instead of just having a knockoff version there, which there's tons of knockoff versions in all the different systems that we're talking about, let's go right to the source and let's agree that we may not do things exactly like Annie O'Connor is doing. But if Annie O'Connor was in the treatment room with us, she'd be proud of the way that we're implementing her model. And I think that's a real important point because we're all going to be a little bit different, in what we're doing, but we need to understand like what are the high points and the low points from these different systems. And then those all can be implemented in one model. And if you do that just 2% better than when our lives are over, we've moved the profession forward. And I think that would be the big take home. And like when those congresses or those super seminars, when set up well, the profession or the professions, if you will, they're one step further than they were before that weekend started.
Yeah, I agree.
Taylor.
I think my big takeaway was there's so many. I'm like literally the luckiest human being alive. I mean, I've only been in practice 6 years, but I've been able to be around these absolute amazing people, and I think they're all saying similar things. Meaning they're all beating similar drums. We talked about palpation earlier. Like all of these people that have amazing careers, that are revered as amazing clinicians, they're all doing relatively the same things. They're just having different approaches. So, Brett may look at a patient and Michael Leahy may look at a patient from a different lens, but they're getting to the same endpoint. And I think that's something that we should all strive for is continuing to beat the drum on assessment leading everything. We're both McKinzoids. I know you're a McKinzoid too, like assessment drain that leads you down every single path you can. And I think that was one of the things that I really took away from the weekend is the assessments may look a little bit different and the treatments may look a little bit different, but the goal is relatively the same. And the end result is usually the same. And so I think just continuing to pay attention to your patients, listening to them, listening to how they're moving, whether that's through your hands, through watching them, through asking them questions, paying attention every single patient, every single encounter will make you a better clinician at the end of the day. And if you do that for weeks at a time, months at a time, years at a time, you will be so much better than you ever imagined you could be. And you're going to help so many people throughout your time. Like that I think is the biggest takeaway for me.
And knowing I think the biggest, you're not going to use all these techniques at once, like understanding like when you're going to use Dr. Kolaj's work, like maybe if we're dealing with an acute derangement, like DNS doesn't make sense real early on in those cases. We're using directional preference, and then hopefully we centralize or abolish the patient, and then we put on our DNS hat, our soft tissue hat. And I think like knowing the timing of the techniques is a really important point as a young clinician.
Yeah, that's on my end. I have not as prevalent as you guys, but I have some teaching that I do, and it's really how to fit this in. And I got
you're moving it all yourself, Dino. So I mean, yeah,
don't
I got
downgrade
asked
that.
to present a case study, webinar, and I'm like Taylor Swift. It's me. Hi, I'm the problem. The case study I'm going to present on how to integrate that is my failures with my own back.
Yeah.
And you'll see like the layered approach from anything from getting into my brain, I can fix myself, to directional preference, to looking at breathing patterns, to what kinetic chain leakages, to eventually strength training and conditioning. And yeah, I agree. How to fit somebody in a systemized manner to move them down the path from pain to performance. And like you said, it's an art and a science, and you guys teach it. Speaking of teaching, I appreciate and respect what you guys do so much, trying to make the profession better. What's upcoming? What courses do you guys have on the docket?
Well, we have a really big one. We're on the agenda of the Neurodynamics World Congress. This is a challenge that Brett and I have stated that we're going to try to do a World Congress every year. And so this year we're diving into DNS. And so this June 14th through the 16th here in Chesterfield or in St. Louis at Logan University is going to be the DNS World Congress. And this is a unique opportunity because Dr. Kolaj hasn't been to the States in
since pre-COVID.
Yeah, pre-COVID, 6-7 years. And so we're bringing him and Elena Kovasova. And if you haven't heard the name Elena Kovasova, she's kind of behind the scenes of DNS, but she is literally a world-renowned neurologist. And so we're so excited to not only see Dr. Kolaj get to work on patients and lecture, but to also hear Elena's take on DNS. And then all of the United States DNS instructors are going to be here in St. Louis with us. And so they're all going to have a part. It's going to be similar. So it's not as much of integration where we're pulling in multiple different, schools of thought. It's going to be more on DNS is different from Brett, from me to you, to Pavel, to Rich Holm, to, Michael Rentala. Like they all kind of, the principles are the same, but the approaches are a little bit different. I think that's going to be a really unique opportunity to see how your approach can change depending on your practice style, whether or not you're seeing patients every 15 minutes like we are, or maybe you're seeing a little bit more extended times. And so it's going to be really great for hands-on, but then also the conversations about DNS and its applications are going to be really special.
I got a text today from Annie's coming. So Annie will be there. Nice. So, just having her in the room would be worth the price of admission, is to get her interpretation on everything.
Yeah.
She'd be a great MC. She'd be a great MC.
Yeah, exactly. And then we've also got, we run out all sorts of things. And so we're lucky we have the pediatrics courses coming to the United States for the first time. And so Marcella is coming in August, and then Martina in October for pediatrics 1 and 2. Every year we run out the A, B, and C DNS clinical courses. And DNS manual therapy is something that you're super excited for, Brett, the first time you're teaching it down in Jupiter. And one of my big mentors, his name is Greg Dorr. He was one of the originators of Factor, and I absolutely love his kinesiology taping course is it's the best in the world that I've ever had, and it's the reason that I've been able to get in with some high schools and to get a little bit of credence when it comes to hanging out with ATCs and other people like that. And so we're super excited about that. And then a subtle plug is our podcast. You do a great job with yours, Dino, and we need to have you.
You guys got a laundry list of awesome speakers. I listened to it. I've listened to some of them twice. There's so many clinical pearls. The ones I've listened to twice usually involve Thomas Shaw.
Yeah, right. That
man's forgotten more than I'll ever know.
I know.
We got our big one this week. We got Christopher Powers on, the big ACL knee researcher. So out of USC. So that one's coming this week. And so we'll.
Yeah, that's kind of our life, is travel around and do podcasts and drink too much wine and, get to hang out with good people and good coffee. So those are our vices.
Last question. Let's close it down. Where can people find you? If somebody wants to reach out with a question, how do they find you?
Yeah, you can go to gestaltedu.com. There's a little contact form on there, and that's where all of our link to our podcast is, and then also all of our courses and things like that. So that's usually the easiest way. team@gestaltedu.com is also our email address. And, if you have specifics for Brett, I can always forward them on, and we'll always get back to you.
All right, gentlemen, thank you so much. This is the We Fix Pain podcast, episode number 21 with Doctors Winchester and Premer, to recap the Neurodynamics Congress, and we are signing off. Thanks, guys.
Thanks, Dino.
Thanks, Dino.